10/31/11.
There's gonna be two.
Yeah, I see it.
Yeah,
Yep.
yeah, there is. Well, that's to pick a particularly complicated billing period. I could do that attention. Trash tonnage, so there's a breakout on the ticket of quantity 6.88 tons. So we can document, the cover sheet is what we paid, but I think the more relevant issue is what our tonnage is, because you're taking your formula and working back off the tonnage. So we just ask that we be charged for our tonnage, especially going forward.
And we used, is it May, June, July, 2012, that was kind of our base?
Yes.
Baseline.
So essentially what they're saying is just revise to their actuals instead of the projection. So, which is pretty much what everybody else is asking, is revise the assessments based on their actuals, since we have an entire year of actual rates versus the projections. And in some cases, the ones that didn't appeal knew that or happened to look into the sample period that we used was their down period. So we have some businesses that did quite well with their assessments. So
You said a 2-year, on here, that says 20-yard, what's that, 20-yard services or 2-yard services?
they're both.
They got both.
They have the two-yarder, which is like the basic office waste, and then they have their roll-off for, I'm assuming, construction.
That was during construction.
Okay.
Yeah, our standard is the one that sits by the office, and that's a 2-yard. And that's, you just see every month is just that's the recurring $112 or something like that. 71, 16, 2011, and now it's a little bit more. So.
What other questions do we have? Definitely probably one of the most detailed layouts that we've seen as far as like invoices and total tonnage, so. Any more questions for us? Make sure you guys contact information.
Yeah, it's inside the cover. Chase has my email and phone number too.
Okay. What we'll do, you know, what we're hoping to here before the end of the month is deliberate some more on how we're gonna proceed with doing any adjustments. But, we appreciate you coming up and presenting evidence, and we'll be in contact with you. Likewise, you've got our contact information, hopefully. Please contact us if you have any questions or anything further.
We're gonna wait till we go through all the appeals.
Yeah. Which I think we're looking at this month, is that right?
Well, yeah, of course, I doubt that, how many people show up on the 24th, we may not get them all done. We would have it by early July, so we can come up with a rational. So we do.
The bills go out when they go out, and we're fine, I'm sure. I just appreciate the invitation.
You are, I mean, that's 50%, and there's another 10% or so given back too, in addition to that, so.
We're as concerned prospectively, that we have a snapshot that's a reflective
Okay.
period of history for us.
And then, outside of this, I think for 2014, that we have a new solid waste committee that's analyzing different ways going forward in 2014. So there may be a change to this system. Instead of a solid waste fee assessment, possibly looking at something with a tipping fee, but.
Particularly for the, those that we can measure, so I mean, that would fit right into what you're proposing here.
Well, but, if it's an estimate, we just want it to be an estimate based on a more respective snapshot, but
Sure.
it's not an easy one.
Well, I don't want people on this, I spent a lot of sleepless nights thinking, well, what's the best system?
Yeah.
and there ain't, the best system is everybody take care of their own trash.
Yeah.
And you know what happens with some people, they don't find the solid waste, at the transfer station, they find the ditches.
Yeah, sure.
And so, you know, I don't care what system you do, somebody's probably gonna pay a little more than they should, and some are gonna pay as much, you know.
And nobody's gonna be real happy about how you calculate a unit because everybody's waste has different densities or compaction.
Exactly.
Yeah.
Thank you very much.
Thank you, appreciate it.
Appreciate it.
And thanks for your time for everything.
Entertain a motion to close the hearing. Second. All in favor, signify by saying aye.
Hi, how are you?
Excellent, how are you doing?
Ready for you.
Pays insurance? You got it.
I work with Kevin Cummings.
Oh, yeah, absolutely.
Does a great job for us.
Thank you.
We know Kevin.
Another
We know Kevin well.
Seems like everybody knows.
I know Kevin well. I remember him especially from the football days, so.
Maurerville?
Yeah.
Yeah, great guy.
Yep. Yeah, want to introduce to Sarah Martin. She is our National Services nationally, also a pharmacy benefits practice lead for us nationally. But she heads up a large portion of our healthcare reform, not just in our local office, but across the country. But for me, it's nice because she's 2 doors down, so she's a huge resource for us. We know us now for a year and a half, and we're thrilled to be able to pry our way from one of our competitors. So she does a very, very good job for us. Appreciate your time as always. Today, our focus is going to be on the change of 2014 and the healthcare reform analysis specific to the county. As you'll see for your group specifically, pretty cut and dry. That's not always the case, but it's a pretty straightforward situation with the county. So I'll kind of set things up and get this going, and then turn it over to Sarah for her portion of the analysis. I know we allotted an hour. I honestly don't think we'll need that to get through that, but I just want to be conservative there. So, to get started, if you wouldn't mind, just go ahead and turn to page 3. I want to explain what I've got here. You know, we showed you this contribution strategy as we went to renewal last year with some options. So what we've done here, and this is just kind of a backdrop for our financial analysis of healthcare reform. What we've done here is if you look at the rate factor 1/113, those are the current rates, employee and employer portion. What we've done for purposes of this analysis, not knowing what rates are 1/114, we've trended those rates forward 10%. 10% is at the average medical and RX trend we're seeing right now in the marketplace. So that's, when you see the rates in the middle projected 1/114 rate, that's what those are, the projected forward 10%. What you see in the yellow are the current employee contributions by tier. Keep in mind, like we did last year, 95% of your folks are in the Blue Cross Blue Shield Plan A. So for the purposes of ease of looking at this analysis, we go ahead and make assumptions that all those people are in there. Those rates aren't that different from the other plans, it just makes it a little bit cleaner to look at. We've already got enough numbers on the page. So in the green, what we've done,
Do you have another copy of this, or?
I do.
You go here first. Okay, thank you, sorry.
Oh, no, no worries. Sorry about that.
No problem. We're on page 3.
On page 3.
Page 3. Sorry.
So in the green, what we've done is for all tiers except for employee only, we've just assumed that those contributions, the employees pay the same percentage as they do today of that total premium amount. The employee only at 15 and 55, I know the county would have been sensitive to that amount, that actually got bumped last year from 0, so we've kept that static and the same as it is in 2013. But all the other dependent tiers we've bumped to where, for example, FT1, non-tobacco, employee spouse, in 2013, they were paying 16.29% of the premium. Now they're still paying 16.29% of the premium, it's just the premium that's 10% more than 2013, so we turn it forward. So, this is again just kind of a backdrop to the analysis. The numbers on the bottom right, you'll see where it says that the county pays and the employees pay. The very bottom right, the numbers for the employee is $211,860,
Okay.
and $1.307 million for the county. you'll see those numbers in our analysis, and that's how we arrived at these numbers. I just wanted to explain the backdrop. Okay, so moving forward on to page 5, before Sarah gets into her analysis, I want to kind of provide a high-level overview of the healthcare reform landscape for 2014. Essentially, the biggest piece is financial risks available, that are there for some employers, some client groups, and a big piece of that is the individual mandate. That's the big piece of legislation. Everyone will be required, 1 of 14, to have coverage somewhere, group plan, individual, Medicare, Medicaid, et cetera. So as such, there are a lot of considerations for groups like the county as far as what you offer to your employees. There could be employer penalties if you have unaffordable coverage. Unaffordable, we'll get into those measures, and you have folks that fall between 138% and 400% of the federal poverty level, and as such could qualify for a subsidy in the exchange, and then go to the exchange. If all 3 of those happen, it would qualify for a penalty of $3,000 for each employee that does that to the county. What we're going to look at is, we'll get to it, get too far ahead, but your coverage is affordable, so it's not going to be, it's not an issue, that possibility is not going to exist. The biggest risk for most employers, if they are affordable and they meet all the qualifications for the coverage they're offering, would just be additional employees joining the plan. What we'll see again is, that's not much of a risk for the county. Where your contributions are, you have the vast majority of your folks that are eligible are currently on the plan, and the ones that aren't, we're talking 12 folks, most of those are on a spouse's plan or still be covered up to 26 on their parents' plan. So what we'll see is there's just not a lot of exposure at all to the county. It's a very, very cut and dry situation, but I still wanted to kind of walk through that legislation. Employers would have the opportunity to completely terminate the plan in 2014. If you do that, you pay a penalty. For just as high level for, hey, we don't have any clients, we show them that option, let's see what that looks like financially, and we'll get into those numbers in a second. But we don't have any clients that are seriously considering terminating their plan. There's costs associated with it from a penalty perspective, even though that might be less than the cost of the healthcare plan, sometimes significantly so. Then you have retention, then you have recruiting, and on top of that, it ends up costing the employees, we believe, a lot more money in exchange in such situations. The costs for the exchange are projected at this point, you can weigh in more there, but there's a lot of concern that the cost of coverage in the exchange is ultimately going to really, really spiral out of control. A lot of the thought is,
As in like no cap or
well,
unknown costs?
yeah, just the thought is that wherever they start, they're going to attract a lot of negative risk. People that actually have no other choice for coverage are going to go there. So the risk pool, the risk mix, for lack of a better term, in that pool of insurance can be very, very poor. As that gets worse and worse, the costs go up, and that situation kind of cycles because then you have the worst kind of adverse selection coming into play, where the people that continue to have to pay that higher premium, people that have no choice and have to have it because they're poor risk, and then it just kind of gets away. There's a lot of thought that it could go that direction. Bottom line, I think in general, there's a lot of confusion about the exchange. I think a lot of people, there's still people that think, hey, the effective 1/14 is going to have healthcare coverage, it's free, those sorts of things. It's not the case. And there's just a lot of questions at this point about how affordable those options in the exchange are going to be.
So we're really only obligated to the employees.
Your obligation is really to the employee. There was some concern, and so much of this legislation has been a moving target. There was a lot of concern that the affordability, et cetera, would apply to all tiers, family, dependent, et cetera. That's not the case. It's just the employee piece. So what a lot of client groups are having to do, if they're not affordable on the employee piece, is to drop that down to a measure where they can be. They're really high up in dependent tiers. So there's a lot of organizations making some very, very difficult decisions. Again, thankfully for the county, you're at $15 on the non-tobacco rewards. I mean, that's incredibly affordable. And we'll talk about what those measures look like here in just a moment.
That doesn't have any effect on because we've offered it, and we've asked them to pay $15, that doesn't have an effect on the new healthcare law. We don't have to provide it all.
No, sir.
You can, okay.
No, you have to provide it, and, you know, they afford it, but, one quick thing before we head into that. On the individual coverage mandate, where people have to get coverage, if they do not, and that's the thing, a lot of people that don't have coverage today won't elect coverage now, they have to pay a penalty. There's not a lot of teeth in that. In 2014, it's around $95 per adult annually, or what's higher, 1% of household income. You know, for these folks, if it's lower income, it's currently not electing coverage, that's not a lot of penalty. And it's gonna be assessed on the tax return. Some of these folks, to be honest, are even paying taxes. So we don't think it's got a huge impact. They are stair-stepping that up. You'll see in 15 to 16 to 2, even 2.5% of that gross income. But initially, there's not a lot of disincentive to not elect coverage.
Have you heard on the exchange, what is the deductibles? Because we've heard that they announced that, but I've heard that the deductibles are gonna be $25.
Well, in the exchange, they have several different levels you can choose from. So anywhere from a bronze plan, silver, gold, and platinum plan, and they have different actuarial values. And so, like, the platinum plan will be the richest plan, it has a 90% actuarial value, so it'll have a deductible. They could actually vary and still be a platinum plan, but it could be somewhere between 100, 500 at the most, I'm guessing, to get to about a 90%. Or you could be in a bronze plan, which is a very bare bones plan, the deductible may be $2,000, $2,500. So you have a choice, but if you want to buy up to a richer plan, you pay more.
Yeah, so, okay, I'm just looking at the basic.
Yeah.
Percentages of caps, where it says it's a 60% plan is a bronze plan, it's 60% up to a dollar figure.
Yeah, the 60% is the actuarial value measure, which means if a plan is a 60% plan, it means that of all the allowed medical costs, the plan actually covers 60%. And then the member of the plan covers the other 40% on average through deductibles, copay, co-insurance.
Oh, okay.
Yeah,
So
it's not just the co-insurance, it's the whole plan taking
Yeah.
consideration. Yeah. And 60% cert point is really low. We'll show you what your plan, this plan A, what most of your folks are came in measured as, just as a point of reference. But 60% is pretty bare bones. It's a high deductible. There's going to be caps on the out-of-pocket maximums for total employee cost sharing, so that's figured in. But it's a pretty bare bones plan to get to 60. And there won't be, correct me if I'm wrong, but there won't be in the exchange, you can't elect for a 63% plan or whatever. It's 60, 70.
So they increased the HSA contributions in 14, I
Yeah.
didn't do that.
Yeah,
Not that a lot, but.
That's what the HSA maximums is what they lined up,
Yeah,
the new out-of-pocket maximums for all plans against.
they're pretty much gonna kill that as it is, I think.
Well, and they kind of already went that direction a little bit, dropping, this year they dropped the max to 2,500 and all that, so. What's that?
Why are they trying to kill those?
I don't know that they are per se. There's all kinds of conspiracy theories involved with that, but, the reality of it is, at its root, if you think of an FSA as a plan for completely known expenses. If you're putting aside money that you use or lose it, you're saying these are known expenses for people. And, there's one theory that, hey, if we're cutting back what people can do that, we still know those dollars are flowing through the system, and we're getting that much more tax money as the government for that. Maybe that's partially funding some of these initiatives. There's lots of conspiracy theories along those lines, but the reality of it is, some folks believe they're going to continue to cut that. We have not seen anything, but that can cut any further, in 2015 or anything coming up, but.
That we know of.
That we know of, yeah.
My theory was that they backed into it, that they figured out they knew how many flexible spending accounts were out there, and because that's that much, pre-tax,
Yeah.
income that they're reducing. So
Yeah.
now they have more taxable income, I guess, that would
It's just-
say, if you're in that plan.
They just generate income.
Yeah.
But if those dollars are known quantity, you're still going to funnel through the healthcare system, and people are just going to have that much less tax advantage, so. On page 7, you look at the affordability piece, and again, we've established that the county is affordable, we'll look at that. I did want to explain that rule. on a very high level, to be unaffordable, again, all we're looking at here is the employee-only contribution. The employee-only contribution would have to exceed 9.5% of household income. Most clients do not know what the household income is, so for purposes of analysis, we just base that off the employee's income. It's plain and simple, it's more conservative, et cetera. On page 8, you'll see there's several safe harbors for clients to determine if they are quote-unquote affordable. The most cut and dry of all these is the federal poverty level safe harbor. You know, it bases essentially 9.5% of the federal poverty level. If you're below that, no questions asked, you're affordable. That amounts to about $91 a month. So at $15 or $55 for your tobacco or non-tobacco, by either measure, well below that threshold, you're affordable, and as such, you cannot trigger any penalties in the exchange, even if someone were to go. So it's very, very cut and dry for the county. Page 9 is a little graphic, a little chart we put together, just to kind of, again, speak to the three prongs of employers' responsibilities in 2014. You have to offer minimum essential coverage to substantially all, 95% of full-time employees working an average of at least 30 hours a week. Minimum essential coverage has been a little bit of a moving target, but what we found out is there's not one of our comprehensive group health plans that's not offering minimum essential coverage. The plan has to have a minimum value. That's the actuarial value we just spoke of. It has to be at least a value of 60%, which is equivalent to that bronze plan. The plan A that you offer comes in at a 78% actuarial value. And most of our group plans, sorry if I'm wrong, most of the ones I've worked at come in somewhere between mid-70s and high 80s. So somewhere approaching the gold range. Gold is 80%. So you're right in line with where that's.
People listing all those, the platinum all the way down to bronze, is that listed on here somewhere?
It's not. The platinum's 90, and it just goes down by 10.
Okay.
Yeah, gold, and silver at 70, and bronze at 60. And then the affordability piece, which we've already talked about, 9.5%, just using the federal poverty level safe harbor, Ashland County is well below that. You know, full-time, single contributions, $15 for non-tobacco, is what we base that on, but even if it's $5, completely meets that, by far margin. One thing they have recently come out with, the wellness piece is a little bit of a moving target, but if clients have a tobacco, non-tobacco differential, they've recently come out and said that you can base that off the non-tobacco. Is that accurate?
That's correct.
Okay.
But again, for you, they're both below the $90, so.
And yours are kind of a hybrid of tobacco and wellness. And I know, like, talking to Linda recently, now they call it rewards and non-rewards, and kind of changed the name of that. Yeah.
Okay.
Yeah, but by either measure, you're completely affordable there, so it's not an issue. Some other plan designs and considerations on page 10. Again, we spoke about this, but out-of-pocket total cost sharing is being capped for plans at $6,350 in-network single and $12,700 in-network family. That lines up with the HSA compatible high net health plans at those mandated amounts. Well below the threshold there, your plan is completely compliant. One other thing I want to point out with all these rules, obviously the markets are going to take place from 1/1/14, looking at the private market for some more options for the county. If you have multiple plan offerings, you only have to have one offering that fits into all these buckets. You know, if you have two plans and one of them is affordable, meets all these requirements, and is offered to all employees in 30 hours, that's fine. You can still offer a second plan. It doesn't have to be affordable or any of those things. Only one has to still fit into that bucket. It just has to be offered to all employees over 30 hours.
So in other words, they chose to look at the plan, because it's unaffordable.
Yep.
That burden's on them.
Absolutely. Yep. As
As
an
employer,
employer,
there's two options.
as an employer, you're meeting your responsibility by offering one plan to all working 30 hours or more that fits into these buckets. That's our responsibility. One thing that is on the horizon that could be a pretty significant change the way plans operate in regards to out-of-pocket maximum is, it's still a bit of a moving target, but What we're interpreting the legislation to say in reference to the out-of-pocket maximum is that all forms of employee cost sharing for essential benefits accumulate towards that out-of-pocket maximum. That's different because historically, in a PPO, style plan, deductibles, co-insurance, those all accumulate towards out-of-pocket. But fixed co-payments, prescription drug co-payments, ER, offices, those historically have not accumulated. Those have just been, you pay your co-pay, it doesn't go towards that out-of-pocket deductible anything. So if that is in fact the case, and those now have to count towards that, that's gonna by nature make your plan a little bit richer. So it's something to consider. Some groups are, in response to that, looking to maybe 1114 bump up their out-of-pocket maximum, if they're well below the threshold, which you guys are, to kind of offset some of that additional expense by the plan. Because essentially what that's saying is, folks will reach that out-of-pocket maximum that much quicker if those are accruing as well towards that total. So it's something we want to consider plan design-wise as we head into 1114. Waiting periods for health benefits, all these offerings have to be offered to employees within 90 days of employment. The county, I believe, is first of the month following 30 days, so you're within compliance there, that is fine. And then the benefit eligibility, hours worked, it has to be offered to all employees working an average of 30 hours a week. I know the county, currently, it's kind of set up different that way. Your full-time is established as 37 and a half. And again, for purposes internally, full-time can be semantics, et cetera. For purposes of health benefits, all employees working an average more than 30 hours have to have this offering, have to have it at an affordable rate, et cetera. I know you currently, if I understand this correctly, offer full-time is 37 and a half or more a week, and then part-time. So people are getting benefits off of them at even the health plan at 20 hours or more, is my understanding. But they pay a different rate for that. Going forward, and like I said, even easier to be in the private market, but regardless, so anything 30 hours or more, people have to be offered the coverage, and they have to be offered that affordable rate.
Is that common, like on companies you do stuff with employees with like 20 hours or more offering, do you see that?
It's not really very common. The vast majority of our clients aren't even willing to make change here, because 30 is the norm.
Probably need to look
Yeah.
at updating our.
And I don't think, if I'm looking at the census,
Annual.
we included them, I think there was maybe one or two part-time folks, currently enrolled in benefits. So it does not appear to be bringing on much additional exposure there by any means.
Not necessarily going forward, what if we have additional, I'm just curious of what the average or what the norm.
Yeah, like again, 30 pretty much is the norm.
Okay.
Yeah, so I don't think by any means you're putting yourself at a disadvantage for employees or anything like that by that, and especially with the mandated legislation. But 30 is the norm. We will occasionally see a 35 or a 32. I don't have one client that has that set below 30 currently.
Good to know.
Yep. So with that said, and as a backdrop, I'll turn it over to Sarah and let her present her analysis for the county.
Okay. So just on the introduction here, we have made some assumptions throughout this analysis. I'll point them out as we go along about household income, what we think the exchanges will cost, and all of those assumptions are detailed in the back, but again, I'll point them out as we go through. So on 13, we've modeled 3 different scenarios for you in 2014 and then also in 2018. 2018 is an important year because there is an excise tax that comes into play, so we'll talk about that. But basically, we've modeled maintaining your current plan how it is today. We're going to show you what it looks like if you were to terminate the plan. And then we're also going to show you what it would look like if you changed the plan design to achieve a 60% actuarial value plan. Again, that's the bronze level plan, and that's the lowest you can go without triggering penalties. So it's not that we are suggesting you make that drastic of any plan changes, but just to give you a range of what kind of savings you have available to you. So on 14, the first thing we look at is where employees fall relative to the federal poverty level. If employees are below 138 poverty level, they would be eligible for, expanded Medicaid if it's expanded in the state where they live. I think Kansas, we're still a little bit in flux there, so these 4 individuals, I can't tell you for sure if they'd be, eligible for expanded Medicaid or not. Each state gets to decide, whether or not they're going to do that, as you may already know. If they do not, become eligible for expanded Medicaid, they can either, just stay on the plan. They all happen to be on the plan today. It's very affordable for them anyway. Now, there are 110 employees that are between 138 and 400%. These 110 employees, if your plan was unaffordable or if you terminated the plan, they would be eligible for subsidies in the public exchanges. However, your plan the way it is today is affordable, so they are not eligible for subsidies in the exchange. And then you've got 25 employees over 400%. And for this group, even if you were to terminate the plan completely, they would not be eligible for any subsidies in the government exchange because they're over that 400% of the federal poverty level. This team here, we look at affordability, and I think we've talked about that quite a bit, but no one is expected to pay over 9.5% of their household income for coverage in the single-only tier at $15 per month. So we don't expect anyone to be eligible for subsidies. So on 16, really the key for your group is looking at plan migration, so movement in and out of the plan. And you only have 12 employees who aren't on the plan today. So really your maximum risk would be those 12 joining your plan because of the individual mandate. However, 7 of them are married. And so we are probably pretty sure if they're not on your plan that they might be on a spouse's plan. Also, 3 of them that are waiving coverage are under age 26, so it's probably likely that they're on a parent's plan if they're not on your plan today because it is so affordable.
Yeah, and it really all just comes back to employee contributions. Like I said, a group like the county where you have $15 individual contributions a month, it's hard to imagine anybody's really not taking that unless they have another option.
Right.
Incredibly affordable, and that speaks to why, of the 127 of the 139 eligible are currently on plan. It's exactly what we would expect it to line up like.
So for purposes of modeling, we think that those 10 employees are probably not going to join your plan in 2014. They're probably getting coverage elsewhere. So we're showing 2 people joining, so 2 out of those 12.
But if their situation changed, if their spouse's employer decided to only offer a plan, they may come back and then we would.
Absolutely, right.
As long as we offer it, it's still.
Yeah.
Right.
And the other wild card there too, Mike, is a good point, is not only is, it's hard to say what the marketplace is going to look like, but not only do you have those 12 folks, 7 of which are currently married and electing their spouse's plan, but then 2, currently some of your single folks that are married, other employers might be making difficult decisions, like we spoke about earlier, bumping their rates, et cetera, that might, you could potentially have some spouses come join your plan. The good thing is, your employee spouse coverage, your family coverage are not, they're not incredibly low relative like your employee coverage. What I mean by that is you're not what we would call necessarily an attractor on the dependent tiers. You're not always going to be the most attractive option from a cost perspective out there. So I don't believe you bring a lot of risk on yourself that way. But there's the potential to have a couple people moving out of the plan from that as well.
And what's the average, just looking at that, like 91% of our employees, you know what's about average with other companies that you're working with?
As far as your participation percentage?
Yeah.
Well, most insurance contracts, whether they're self-funded or fully insured, a lot of them like to hover around that, hey, you require 70-75%. That tells you anything, so that's kind of an average.
But with your contributions so low, I think that's pretty normal. I mean, I have some groups where employee only is $200 a month, and so their participation is going to be 50% or something like
Yep.
that. So it's completely a function of what you're charging.
One part of, the reason why we have, and you probably know this, is just because we're on the state of Kansas plan, we're capped at how
Right.
much we can have an individual employee
Okay.
contribute. So,
Yep. Well, one positive of that limitation, at this point, is it's set you in a pretty good spot after a point where you don't have to make a lot of difficult decisions along those lines.
So page 17, just so you're aware of the penalties that are out there, the plan sponsorship penalty, if you were to terminate the plan, is $2,000 per full-time employee for everyone. You get 30 employees for free. So based on, your number of full-time employees, it would be 218,000 in 2014. And so all employers are facing this if they decide to terminate their plan, and then this amount gets indexed with medical inflation every year. So just so you're aware of what others are facing.
Does that penalty change year to year? There are some things that each year the penalty phase does change, so
Right.
that may be effective in 2014, but what happens, is there any projections on that?
Yeah, right now, the regulations say that it can be increased with medical inflation, which, I mean, it's medical inflation, just, I'm not sure how they're going to calculate that, but that could be anywhere from 10% on up. And they
So
can
that's,
really
that's the
do,
only factor, I mean, they can't come in.
Right
because
now.
There's so many things that they're adding and writing now,
Mhm.
that who's to say in 2015 it could be 25?
Exactly.
There's no firm way in the legislation saying that they can't change that amount.
That's the point.
Yeah, you're exactly right. We have seen nothing to say that's gonna be a graduating scale, but there's nothing in there that says firmly this cannot
Because if they
change.
come up short of money, and these exchanges get too high for people, then what better way would there be
Sure.
to force people back in by adding a little penalty?
Yeah.
Okay, sorry.
No, it's
No,
not a
that's
good
a good
question.
point. The next two penalties, again, if you were to provide unaffordable coverage, or if your coverage did not meet the minimum value requirements, then for each employee that goes to the exchange and gets a subsidy, the penalty is $3,000. And again, same thing, right now they're saying that's indexed with medical inflation, but could change. So on page 18, we're showing you the different scenarios here. In the first column, we have 2014 before the impact of healthcare reform. And so we're just showing 127 on your plan, 12 waiving the plan today. This 1.3 million, this is based on the projection that Dan showed you, what we think your cost could be in 2014, which is assuming that 10% medical trend. And then the employee contributions down below, the 200,000. We are showing some tax offset, obviously not corporate tax offset for you, but, because benefits are, pre-tax for employees, we're showing that offset. Penalties are not tax deductible, so that's something that impacts, corporations who have corporate tax. So the next column over, really all we're showing here is those two employees joining the plan, so your premiums go up slightly. Again, if you had more than two, then it would go up proportionally.
Which column is that one, Sarah?
The one, 2014, after healthcare reform, aging plan.
Oh, so that's the second column, you said?
Yes,
That's where the two join, okay.
right,
It really just shows your portion of the cost of it, $2,000.
right.
This is the part that, when I said early on, how clean cut it is with the county, this is the part that's very interesting for a lot of employers. I got a client that Sarah and I were meeting with a month or two ago, it's a construction company that currently suffers to get much more than 50% participation. And so the wild card, and they're 5% life group. So are they gonna have 50 folks join the plan, or are they gonna have 400? And that's where, the potential for cost, and it's just tricky. Thankfully for the county, the realistic, implication of this is we don't project to change in your enrollment much more than we would just throughout the course of a normal year, looking on our offer plan, hires, terms, et cetera. There's just not much going on, there's not any potential exposures.
So So the third column shows, the scenario if you were to terminate the plan, so there's that $218,000 penalty in 2014. If you look down below, under employee costs, that 1.087 million, that's what we think, the exchanges would cost your employees if you sent them all to the exchanges and put them in the, and they all chose the silver plan, which is the 70%. And this number is just based on, the Congressional Budget Office estimate of costs for the exchanges. So again, we don't know exactly what that will be yet. And then for your particular group, based on everyone's salary, we look at what subsidies they would receive, and they would get about $488,000 in subsidies. And then the last column shows, if you were to change your plan design and get down to that 60% actuarial value, your premium would drop to about $1 million. Again, not that we're suggesting a drastic plan design change, but you could make that drastic of a change and still remain compliant with the law.
I think on column 3, terminate the plan, that employer or employee cost exchange, that's an unknown, or a moving number.
Right,
That
yeah.
would be risky, that'd be my assumption, when most companies are shying away from terminating, I guess.
Well, I mean, there's two things, and a lot of groups, depending on the size, et cetera, a lot of times, there's not a ton of difference between the bottom line for the employer to determine plan to keep going. There's a bigger spread with you than you would typically see there. And you also, a lot of times, the burden, whether moving or not, the burden on employees is projected to be pretty substantial. And that's, of course, what the CFO, just financial hat, doesn't consider the retention and recruitment aspect of it as well.
So 19 is just a graph of what we looked at in the chart, and then 20 is just some narrative around the chart that's there for your reference, but we've already discussed all of that. We can probably move to 21. 21 looks at the year 2018. And in 2018, there's a new tax that's been called the Cadillac tax, but it is a 40% non-deductible excise tax on plans that are over a certain value. So for your single tier, if they're over $10,200 in value for that year, annual amount, then there's a tax, and if they exceed $27,500 annually on any of the family tiers, then there is an excise tax. So basically, we take your funding rate and project them forward to 2018. We're using 10% trends as an estimate. And then in a couple here, you do trigger an excise tax. So for example, on the F1 non-tobacco rate, when we project that out, we project it to be $11,200. The threshold $10,200. So there's a 40% tax on that extra amount for those 25 people enrolled in that tier. That said, a lot can happen between now and 2018 as far as they could move these thresholds. We're making some pretty, significant assumptions about what your trend will be. You can always make plan design changes if you need to lower your funding rates a little bit. So there are lots of things you can do as this gets closer to, manage the impact of this tax.
When you get a couple years out from this, it gives a lot better idea of what it looks like and what changes can be made, if any. What else is interesting about this piece of legislation that we always kind of chuckle about is, first of all, it's interesting to me, there's a piece of legislation that, agree with it or not, but it's essentially saying we don't want you to offer too rich of a benefit. You would pay penalty for that. But what's interesting is, we all know that the premium rates, the funding rates, whatever you want to call them, are as much a reflection of claims experience as plan design. And so what you'll see is, if this is still in place, you know, company X and company Y are gonna be the exact same plan design, but their rates are entirely different because of claims history, so much claims study, et cetera. So it really doesn't even measure the plan design as much as, you know, how's your plan ran. So I think it's kind of an unintended consequence that's interesting, so.
And refresh me on what's considered coverage on the 10-2 for individual and 27.5 for the family. What's included in that? Is that?
That's just, everything we're modeling here off is your plan A, like limits of the contribution.
Okay.
And so what we're just doing
That's
is.
total cost for employer and
Yeah,
employees?
yeah.
Annual?
Yeah, it's just, we're annualizing that monthly premium that you have today, and then trending forward.
If the state would change their allowances and allow us to charge more to employees for that level one care, that's going to change the percentage and will get us out of the Cadillac tax.
Actually, it includes the employer and the employee portion of the cost, so even if you
That doesn't
shift.
have any effect.
Right.
Right, the only thing you could do would be change the actual plan design to bring the total premium down, because you're offering like a less rich plan.
So are these gonna be the same numbers for the entire state plan? I mean, is this saying that the entire state plan is going to hit this Cadillac tax?
Yeah,
Yeah,
those-
it's all the same premium,
Yeah,
yeah,
it
everyone's
is all the same.
does the same.
Surely they're gonna change, the state would have to change their
Yeah.
numbers to avoid the tax, so this really is not going to force that, is it?
I don't envision it. And like Sarah said, a lot of the estimates are very, very, assumptions very conservative, you know, applying 10% return year over year over year, and even doing all those things, some of them are just barely creeping over those thresholds.
Yeah, it's just something to monitor, a
Yeah.
couple years we get closer. So page 22, this is the same as the 2014 chart, we just trended everything forward, to 2018, and then added in the Cadillac tax, so. Nothing else new there.
I mean, it looks like even with the projections, it looks like changing your actuarial value down to 60% still results in decent amount of savings.
Yeah, where you are today at 78, you have a lot of room to get down to 60. Mm-hmm. Yep.
Keep that much change.
Well, but if it's working off the same numbers, I mean, that's correct, but it looks like something's out there through 2008, I know there's stuff moving, but, I mean, just looking based on what they've laid out, I mean, you can have changes in administration, et cetera, but it would change that, but it just looks like.
Right. And then the last thing I have is on page 23, there are a couple other, fees and such, that come into play in 2014. There is the transitional reinsurance program that begins in 2014, and it's a 3-year program. The government nationally is collecting $25 billion to kind of fund a high-risk pool, reinsurance pool, if you will, for the exchanges. Because in 2014, there are no more pre-existing conditions, so, anyone can be in the exchanges, and all of the, high-risk pools will be going into the exchanges, so they're just funding this, money to cover those high-cost individuals. So basically what this means, for everyone who has a plan, the fee is $63, per year for each individual on the plan. So not per employee, but per member on the plan. So that's the fee in 2014. In 2015 and 2016, that fee goes down a little bit. They haven't calculated the exact amount yet. And then the next fee is the Patient-Centered Outcomes Research Institute fee. And this one is just $1 in the first year, per member, and then it goes up to $2 per member. And this fee runs, through up to 2019. And this is just for, medical outcomes-based research. So this is another fee that applies to all plans.
Is that $1 per month?
$1 per member per year. So for your group with, I'm not sure what your contract size is, but 127 enrolled, probably $250 annually.
What do they do? I mean, what are these designed to do?
Well, they just outcomes, a lot of this is based on, they're gonna try to measure outcomes. And so reimbursement sometimes may, if you don't have good outcomes, those medical places will not get reimbursed. That's my understanding kind of the law. I mean, I'm
Yeah.
guessing this is what this is gonna have something to do with some kind of an institute, another government agency or something that's gonna try to measure what facility is being effective, what doctor, whatever. That's an assumption, don't get me wrong.
No, that's exactly right. I mean, the whole, part of the whole legislation and just kind of how the industry is moving as a whole is just towards like patient-centered medical homes, outcome-based, doctors starting to get paid not on how many times you go in their door, but on outcomes. And so how can they change the system to get there? So, yeah. All right.
That's just another good subjective thing that's gonna be interesting to see how they monitor that.
So the next little page is really just some of the assumptions, again, Sarah used in her analysis. Nothing too exciting there. So a synopsis for the county relative to 2014. Your plan is completely affordable, and as such, you are not subject to any penalties for folks that would qualify for subsidy because of these changes. It's not an exposure for you. You really don't have much to speak of at all in exposure for additional employees joining the plan. Where your contributions are set, your participation is already incredibly high. You got a few folks out there, most of those, 10 of the 12 we believe are on a parent or spouse plan currently. So you might really have a couple of folks that come join your plan. So just not a lot of exposure there, not a risk of penalties. Plan design wise, again, involved in the marketing, what that looks like. We need to keep it on the out-of-pocket maximum piece, see if we maybe want to raise that a little bit to offset some of the fixed co-payments that now will accrue towards that. And then the full-time definition is something you might want to revisit and just make nice and easy at 30 hours to match up with legislation. But really, I don't speak for Sarah, for a lot of these meetings we've been on together, and she's done a ton of them that it's about as cut and dry as you could ever ask for, as far as what action items there are for a client. That said, on page 27, just to wrap up, look at some of the next steps. We're very, very close to the time to the market. We've actually already requested a check for the data. The state asked that either be sent directly to them or to you guys to head over to them. I think we've elected to send it here over to Linda. If you guys support the state, we think there's probably less chance of getting lost in the shuffle if it comes directly from you. So we'll be in touch on what that looks like. We will send over, just to refresh, we want to have data through June. That data is usually available at the end of July, so we're trying to be ahead of it. We will want, we'll try to request that data, get you the list that you can request that data for us at the beginning of July. So you can go ahead and request and have that in, and hopefully we'll get it by 8/1, so we're hoping for. That's already in the works. Already had local conversations, kind of negotiating up front and a little bit as much as I can with the carriers, saying, hey, here's what's coming, bit of an unusual situation, and that we need a quote earlier than we normally would relative to the effective date. There's the date of notification of state that we have to work with, so that's already, they're already kind of aware of that, and that's coming. I know a couple carriers have said, would they be open to the idea of filling out individual applications. Typically, you want to avoid that. It's a very, very cumbersome process. It might be a situation where a carrier or two says, we want you to do this, we'll play that layer and see. What we really want to do is get quotes based on the claim experience and the census. That's what we're shooting for. And again, when we get a little closer there, we'll talk a little more about plan design, what we want to see, what we're going to ask them as far as a gauge on the price, and where they are relative to your current ranking with the state. What we're going to ask for initially is a quote based upon that Blue Cross Blue Shield Plan A, that plan design. That'll be the most apples-to-apples comparison. That's where 95% of your folks are. We'll see what that cost looks like relative to the state. Beyond that, if we do have good options there to go to, at that point, we can look at, would we like to offer another plan alongside of that, whether it be a high deductible plan or whatever. But for starters, that's where we're gonna start, see if we've got something that makes financial sense. Also, we'll do the same with, the dental piece, looking at the private market for that, it's currently combined, and then, on the vision as well. Obviously, the medical being a big piece there. From there, once we determine where those are gonna fall, plan designs, then we enter into the employee contribution discussion. You've got plenty of room there, given what we talked about in 2014, maintain affordability, and even make some changes there. If the decision is to move away from the state plan, that's a viable option. You're not hamstrung by those restrictions placed on you by the state, so you have more flexibility to do what makes sense there. Still operate within the framework of the legislation.
I think we've notified the state of Kansas if we do, is that our
10-1?
first?
Oh,
Yeah.
10-1, yeah. And then from there, upper remote planning and away we go. So yeah, that'll be exciting. That'll be getting going here pretty quickly. We'll have it. Jeff will send to you and then Pat an email over with that specifics of that data request at the beginning of July. As long as I would think it's have that fired over then by mid-July, and with the checks and the data, we should be sitting there to have it back to us as soon as they get their hands on it, which we expect to be by 8/1.
If we have a health saving plan with higher deductible, would that save the county money?
In general, a couple of thoughts. High medical health plan, anytime it's going to be a less rich plan design, higher deductibles, et cetera, more cost sharing, it is going to be a less rich plan for the employees, so it would cost the county less, yes. There are other considerations there too, all which we can talk about. Large claimants, the most recent benchmarks, large claimants, we kind of expected last year, we looked, large claimants on average right now, 6-7% of your members are driving around 70% of costs. I only mention that because whether deductible is set at $500 or deductible is set at $2,000, when you have someone with $150,000 in claim, and that's driving a huge portion of your spend and your cost, that extra $1,500 because of the deductible doesn't make a whole lot of difference at that point. The other piece with a high deductible health plan, always to consider, is fundamentally when you have prescription drugs, office visits, et cetera, as opposed to those being a $10 generic prescription or a $25 office visit copay, and those become deductible co-insurance, and all of a sudden the employee is paying $100 for a drug or $80 for an office visit. You just want to be sure. Communication is huge. Educating employees and members on that is huge, and you want to make sure that you don't put anything that is what we call a barrier to care. You don't want a situation where it's too cost prohibitive to go to the doctor or get your compliance medication, et cetera, due to plan design. So it's just a consideration. So as a general rule, yes, the less rich plan design will cost less. In a situation where you're having a tough time with large claimants, it doesn't really make a lot of difference because those are driving such a huge portion of your cost that deductible or out of pocket or just the basic mechanics of the plan differential from the basic plan to a high deductible, it doesn't really offset that many much difference. But we actually, I know we talked about it, and what we like to do is I think what would make the most sense is one of the high deductible health plans coming from where you're at today, which is a pretty rich PPO plan, employees are used to. If you were to offer a high deductible health plan, I think offering that in conjunction with as a second offering would be the way to do it. See what kind of interest people have. Typically, when we see that first year, a high deductible plan offered alongside a base plan, we typically see less than 10% migration to that plan, at least initially. Sometimes that grows depending on how much contribution-wise you accept.
That's true in Ashland County.
Yeah.
There's three of us, I believe, who are on HSAs.
Yeah. And that's pretty normal. So just a couple of thoughts there. And then one more thing I wanted to ask you guys about real quick, and get out of your hair, but have you guys made any progress on the wellness committee?
No, we haven't. Something else we need to work on.
Okay. Well, just curious, whatever, and as we get further down that path, whatever, let us know how we can assist that, and then ultimately tie that into initiatives throughout the year, overall, et cetera.